Good evening, New Bedford Guide. Welcome to Health Plus Weekly. I'm going to be your host tonight, Pete Goheno. Unfortunately, Dr. Pacoa, being a doctor, had something come up tonight and is not able to join us. So I will be hosting tonight, but we have a fantastic show. We are going to be talking about if you or a loved one is dealing with a serious illness, what are some of the services that are out there that you can turn to in order to make that whole process a lot easier. And so with me tonight is Robin Pelletier, who is the Director of Supportive Care Services for Southcoast VNA. And also with me is Lorie Resendes Trainor, who is a Palliative Care Nurse Practitioner with Southcoast VNA. So welcome both to the show.
Thank you.
And I'd like to just start by telling us a little bit about what you do at Southcoast VNA. So Robin, if you don't mind.
Okay, so I've been a nurse for about 38 years, and about 30 of those years have been involved in working in the palliative care and hospice field. As the Director of the Supportive Care Services, I'm responsible for the management of both programs, the Palliative Care Program and the Hospice Program within Southcoast, from a clinical and administrative standpoint.
Excellent. Lorie?
So I'm the Palliative Care Nurse Practitioner. I also have a colleague, Amy Putnam, who's also a nurse practitioner in the area, and we provide consultations in the home and in the nursing homes for patients who have a serious illness.
Excellent. Can one of you just tell us a little bit about just Southcoast VNA in general and what services it provides?
So Southcoast VNA offers a wide variety of specialty programs, orthopedics, maternal child health, just routine home care.
Mm-hmm.
The supportive care services is really palliative care and hospice. And palliative care, I think there's a lot of confusion about what palliative care actually is. Within the palliative care program, we have nurse practitioners, we have a conversation nurse, we have registered nurse case managers, social workers, chaplains, really quite a variety of staff that are able to service the patients that come on to service, home care aides as well. Palliative care, I think, is really for those patients with a serious illness that need management of their symptoms, really to discuss the symptom management, the goals of care, and really to accept the patient where they're at in their particular illness or disease trajectory.
So you mentioned hospice care as well as palliative care. What's the difference between those two things?
So the difference between hospice and palliative care is that palliative care is really for those patients with serious illness, as opposed to hospice care, which is intended for patients with a terminal illness that have a prognosis from anywhere from 6 months to a year, who have exhausted all of their treatment options. Mm-hmm. Patients on palliative care certainly can be looking for curative measures. They might be oncology patients that are receiving chemotherapy and radiation or biotherapy. It's for patients with heart disease and lung disease and dementia. Really, any illness or disease that is considered serious would be appropriate for the palliative care program.
Excellent. And again, to all those who are watching, we welcome your questions. Any questions that you might have for Lorie and Robin. If you have a loved one who is seriously ill and you're struggling with their care and you feel like you need help and you have a specific question, please feel free to text it in. Like we did last week, you can text it anonymously to 508-717-8948. Again, it's 508-717-8948. Or you can comment below in the comment section, ask a question there. Anything that has to do with hospice and palliative care, any questions that you might have for yourself or for a loved one, please, we welcome those. We want this to be an interactive show like always. So there are definitely, I had asked a question, what's the difference between palliative care and hospice care? I imagine that not only do people have a hard time knowing the difference between the two, but then there's also must be a bunch of myths that are out there as well that you have to clarify for people. What are some of the myths that you hear?
Well, one of the things I often hear when I go in to see patients is, oh, palliative care is being called. That means things must be really bad, or my doctor must have given up on me, which is absolutely not true. So our job is to help patients and support them throughout their serious illness. So when I see them, it's to help manage their symptoms so they can lead a better quality of life, so they can continue with their treatments. So I would say that's the biggest myth with palliative care, is they associate it with that's it, or completely equating it with hospice.
So there's a comment here from Crystal, whose mom had end-stage Parkinson's and who ended up using palliative care, and she said it really helped provide comfort measures for her mom. So I think that's an example, and thank you for sending that in, Crystal. It's good to hear those experiences, and I think that's a good example for those watching at home, the type of services that you would provide. What are the illnesses that you most often are providing these services for?
So it's a wide range. So like Robin was mentioning, it could be patients who have an advanced heart problem like congestive heart failure or lung issues. It can be cancer or a loved one who might have dementia. It's really any serious or progressive illness. And it could be at any stage of the illness. Like Robin said, hospice is for patients in the later stages, but with palliative care, we can see them really at any point to offer support.
How are the majority of your patients referred to you?
They're referred primarily by physician offices, clinics. There are times where family members and patients themselves will call and ask for services. And at that point, we reach out to the physician for a referral for the palliative care or hospice program. If a patient, for example, is not quite ready for hospice and they might be eligible for hospice, we use the palliative care program as a bridge to the hospice program. The benefit of that is that the patient and family are able to establish relationships with the providers, with the nurses, with the social workers, perhaps with the spiritual care providers that we have on staff. And so the transition we like to think is a seamless one from palliative care to hospice. But not all palliative care patients, when we go back to the myths, not all palliative care patients transition to hospice. There are times where we are able to improve the quality of that patient's life, and we are able to work with them in pain management, and sometimes they're discharged back to the community to live independently.
Now, I've heard that a lot of times by the time someone gets into palliative or hospice care, that it's later in the stage of the disease than probably would have been preferred, that people tend to wait longer than they should in order to call for the service. When's kind of the ideal time for someone to reach out to Southcoast VNA to have them bring the services to them?
Well, I think the ideal time is when a patient is identified as having a serious illness and they are experiencing symptoms, either physical or psychosocial symptoms related to their illness or disease. That's really the time. We also feel that when a patient is initially diagnosed with cancer and is going to begin chemotherapy or radiation therapy, that's the time to refer the patient to palliative care services. Again, it doesn't mean that the patient is going to enter that terminal stage, but we're there to help with the management of the symptoms. We're there to work with the patient surrounding goals of care.
And another anecdote that I've heard and read, so I mean, I think it's evidence-based, not less anecdotal, but it is just that a lot of physicians, a lot of doctors have a hard time having that conversation with their patients and the patients' families, and there's sort of a culture in this country to avoid it because it can be uncomfortable and can be difficult. So what advice would you give a family member who might have a family member in the hospital now with a serious illness, and they might not be getting the guidance that they necessarily need for the next step, what would you tell them to do?
Well, I think, Lorie, you can talk about the Palliative Care Nurse Practitioner Consult Program, because that's an ideal way in which to become involved in that patient's care.
Yeah, so myself and Amy, we would go to the patient's home or wherever they are in the nursing home, and to establish the relationship, first just asking how much they want to know, what are their concerns about their health. Some patients want to know a lot of information, other patients don't. Everyone's going to have some different concerns about what's going on, so really establishing what the patient wants to know and communicating that to the physician. So our job is to help coordinate the care and to make sure everyone's on the same page and understands what's happening. And once we establish what they want to know and understand, then we can work with them on, okay, what's most important to you, and how do we communicate that with your doctor and with your family.
Do you find which family members do you end up dealing with more often? Is there someone in particular, or does it run the gamut as far as who's usually making that phone call?
I mean, it's usually family could be anybody to the patient. So whoever's providing the most support to the patient, whoever they trust, doesn't have to be a blood relative, but it's whoever the patient considers the person that would be helping them and supporting them. It's whoever the patient wants involved in that discussion.
Many of the referrals we receive were also from the hospital.
Okay.
And so they're identified by the hospitalists, by the social workers, by the liaisons that, gee, this might be an appropriate patient for palliative care. And at that point, we have a new role called the conversation nurse, who is a registered nurse who can go to the hospitals, go to the nursing homes, go to patient homes, again, to talk about goals of care. It's not about us. It's really about what does the patient want. What do they see as their most challenging health issues now? As Lorie said, what do they want to know? What do they not want to know? And so there are a variety of ways to approach those discussions.
So I imagine this is a difficult conversation for family members just to have amongst themselves, and I imagine this time of year around the holidays, in between Christmas and Thanksgiving. I mean, again, a story I've heard recently is a friend. They got together for Thanksgiving, and a parent was very ill with cancer and wasn't able to join them for Thanksgiving. But while they were all together, they decided to have the conversation of what's the next step, what are we going to do here? Everyone in that situation were young, on the younger side, had young families, really weren't in a position to take time off from work or take on the extra responsibility of caring for their loved ones. So I imagine this time of year is a great time, if you haven't had that conversation yet when you're with family, have that conversation and figure out amongst the group how best to, how most people are comfortable. Do you find that families are usually in full agreement about how do you tread the road when you get approached by one family member who might be all about using the services and the other one just doesn't want to face the facts that it's time to turn to this option? Does that happen often? And if so, how do you deal with it?
I think the biggest thing is listen. So listen to all the family members. So usually in that situation, we try to get everyone sitting at the table. So if one is leaning towards one option and another really wants to take a different approach and the patient may be indifferent, for instance, that's pretty common. We all get together, so we say what's most important to you, bring it back to the patient. How did they live? What's most important to them right now? What's your understanding of what's happening? And try to clear up any misunderstandings that they might have. But it does happen that there's some conflict, and that's where palliative care can really help. Our team is very good at, our social workers, nurses, our conversation nurse, at negotiating that type of conflict. And what you were mentioning before, about people being uncomfortable, that's kind of where the conversation nurse came out of. There's a national push to have the conversation. It's called the Conversation Project. And Robin and I are involved in the Conversation Ready Collaborative, which is ensuring that we as clinicians are having conversations with the patients, that we know what's most important to them and that we're communicating that with the rest of the team. So I think the culture is slowly shifting to try to engage people more in this conversation and try to make it more comfortable.
Great.
One of the ways in which we can begin to have that conversation is surrounding advance directives. And so that's often how we will approach what is most important to you, and have you made decisions about how you want to live the remainder of your life. Very often we'll have the social worker, we'll have the nurse practitioner, we'll have the conversation nurse, have those conversations with patients and families, but again, it really does go back to the patient and what the patient's goals of care are and what's most important to that patient.
Excellent. A lot of great information. I hope that people watching at home, I hope this is helpful. We're going to take a quick break, just a 30-second break, just to grab a drink of water, and we'll be right back. And we'd love to take any of your questions. As always, feel free to send them along in the comment section on Facebook, or you can always text them anonymously to 508-717-8948. So we will be back in a few. Thanks.
People, actually come up and they're like, I gotta hug you. And it's like, this is the first time in, X amount of years I've not been in pain. And we get that feedback every single week. Integrating the nurses, integrating physical therapy, that is all part of the treatment strategy, the treatment algorithm. In a matter of weeks, matter of months, they're now able to have the life that they want to live. And that's really more than medicine.
So welcome back. We are here with Robin Pelletier, who is the Director of Supportive Care Services for Southcoast VNA, and Lorie Resendes Trainor, who is a Palliative Care Nurse Practitioner. We are answering any of your questions that have to do with palliative hospice care. If you have a loved one, or if you yourself are suffering from a serious illness and can use some additional support, that's what Southcoast VNA, which is a part of Southcoast Health, is really great at. We do a ton of different things, but the hospice and palliative care services are a great option for those folks out there who are in need of them. And I guess to kick off this next segment here, want to go back to specifically talking more about hospice care. Are there myths, perceptions about hospice care that you come across a bit that aren't necessarily true?
There are many myths surrounding hospice care, actually. Hospice care is intended for those patients that have a terminal illness who may have exhausted all of their treatment options, but hospice care is a benefit. And I think that's really how we need to think about hospice care in this country, as a benefit. It's a benefit that everyone has. The benefit of hospice services is really quite broad. In addition to the nursing and the social work and the home care aides and housekeeping and social work and nurse practitioners, hospice covers all of the equipment and supplies that are related to that terminal illness, and it covers all of the medicines related to that terminal illness. Very often we hear, and I was met with a company about a week ago who really commented about some of the myths, and one of those was, well, my understanding was they said that you stop all medicines when a patient comes on hospice, and that's just not true. Mm-hmm. Most patients are on medicines that are clearly being used to maximize their comfort. Heart disease medicines, or pain medicines, or anxiety medicines.
What about morphine? What about the use of morphine?
So there is a lot of there's a lot of conversation surrounding the use of morphine, and the use of morphine is only used in hospice for pain management or respiratory management symptoms. It's not used on a regular basis if it's not needed. And I think one of the things Lorie and I hear often from patients is, well, I don't want to become addicted to morphine. we hear from other family members, well, it's the morphine that killed my mom or caused my dad's death. And that isn't what morphine does at all. We use morphine in very calculated doses for the management of very specific symptoms, and not just for, a headache or a toothache or a hip ache. It's used very specifically in hospice.
And it's usually used to improve their quality of life, so they
Right.
can interact with their family more and they can feel better. So usually, like Robin said, it's used very carefully and it's a very effective medication. I think the national conversation around addiction has kind of clouded this and made it a little more difficult, but again, listening to what the concerns are and addressing the concerns are an important job for us.
Because there is still a use, and this is something that I think the conversation about opioid abuse is very valid and needs to be had.
Absolutely.
But the tide has shifted in such a way now that anyone who is using opioids for pain management are now slightly embarrassed to admit it because of the stigma now that exists. And I think it's important that we continue as a healthcare organization to talk about that there are a lot of patients that can still benefit. Chronic pain, there's folks who are dealing with chronic pain who can use opioids in a responsible way, and then there's the use for people with serious illnesses that when used responsibly and under the watch of a medical professional, there is still a use of that. So I think the thought that opioids are all bad is not true, and I think it's important for those who are still benefiting from the good parts of that drug, for that notion to be out there, so that folks aren't afraid to seek it for pain management when necessary.
It's appropriate, absolutely.
Right, and I think, addressing the fear and the concern that in hospice patients morphine will hasten their death is a really important talking point, because morphine is never used to hasten a death, and our role is not to hasten death, but to maximize the quality of a patient's life and make sure that this patient is comfortable until the end of their life. But it's never used to hasten death, and I think that is a real misunderstanding in the community.
So we have a question from Joanne. She asks, can you explain what an advance directive is?
Sure.
Sure. So advanced directives, when we talk about that, it's talking about who would make decisions for you and what those decisions would look like. So I usually ask people, if they're very clear today, you're able to speak to me clearly. If you got really sick, who would be your voice? And we want to make sure we have that in writing, so we call it a healthcare proxy. Again, it doesn't have to be your spouse or relative. It's anybody you trust to make medical decisions for you. And we stress the importance of you need to have that in writing and make sure that your physician or your healthcare team knows who that is, so they know who to turn to if they're not able to speak with you. The second part of that is, what are those decisions? So we usually talk about things like resuscitation. So if you were at the point where you needed life support, do you think that makes sense for you at this point in your life? And that goes with a bigger discussion about what the impact of this disease is going to be on your life expectancy. That's certainly going to change your decisions around life support. So that's part of advanced directives, is who's going to make your decisions, what are those decisions, and it gets to the conversation about what matters to you and what are you willing to go through to get more time.
So it's been in the
Great
news.
question. Yeah.
It's been in the news recently about a gentleman actually who had a "Do Not Resuscitate" tattoo on his chest.
Yeah.
I imagine that's not the best way to go about giving that directive.
We do not recommend that. So I recommend that you have it. We use a MOLST form, so if people have seen it, it's a hot pink form. But talk to your doctor about it. If your doctor doesn't bring it up, you bring it up. Tell them that you've been thinking about this. You want to make sure you have your wishes in writing. It's important. It's an important conversation, but I would have it on an actual form for your medical doctors, not a tattoo.
I think, the other important thing to mention is that once you make a decision as to who is going to be your healthcare proxy, you you need to have that conversation with your healthcare agent, letting them know what is most important to you. How do you want to be treated if you are ending near of life and unable to make those decisions, so that it's really your decision as a patient, that the decision is being made by the healthcare agent.
I imagine it's probably best to decide on your healthcare proxy while you're still relatively healthy.
Absolutely. That's ideal.
What do you recommend as far as that goes? When should someone start to consider picking out a health proxy, and are there any other tips for best practice?
So, as part of the Conversation Ready project that Lorie and I are involved in, one of the things that I did was to discuss advanced directives with all of the staff on the hospice and palliative care program, and who had them and who didn't, and if they didn't, how could we help them to get them? We then went back to our families, our own families. I have 5 siblings, and they all have children. Making sure that all of them have had a healthcare proxy initiated, and making sure that they've had those conversations. So I don't think it's ever too soon to have a healthcare proxy. You can always change your healthcare proxy. So if you're 25 years old and you decide that you want your brother or your sister to be your healthcare agent, and then in 10 years you change your mind, you change your healthcare proxy. So it's a decision, I think, that we make at different points in our lives, but it is important to have it in writing. There is a booklet called 5 Wishes that is actually legal in the state of Massachusetts that some people use because it walks you through almost every scenario that you could possibly think about. Again, it's a rather lengthy little booklet, but it's useful for some people.
And definitely in having the conversation, I think it's useful.
Yes, it's useful with the conversation for sure.
We got an anonymous question about, trying to think, they didn't ask in this way, but I'm trying to think it's assisted suicide, I guess, is generally the way people would know it, but the thought of allowing someone to choose their own time, if they have a serious illness, to choose their own time to end their life. I imagine that it's not something that's legal here in Massachusetts, but generally speaking, to get away from the specific question, but generally speaking, what role does a support service nurse or the staff have with the patient when the pain is too much to bear? How do you deal with it when a patient comes to you and just says, I've had enough, I just want this to end, I want this pain to end? How do you deal with that type of situation?
So I'm always going to go back to listen to them and listen to what other things are contributing to that. So certainly treating the physical symptoms, that's our job in palliative care. So we need to treat the symptoms that are causing that much distress. But there's often other things that are causing distress. It could be spiritual distress, it could be family distress. They might be worried about being a burden or being vulnerable to their family. So allowing them to talk about it. We don't participate in physician-assisted death, and we don't have a position on that. That's not our role in palliative care. But we don't shut the patient out and say, no, you're not allowed to talk about that. We don't do that. It's saying, what's causing this? Let's help you. So
And
dealing
how can
with
we
all
help?
parts.
Right,
Yeah.
and how can we help? And it's really a team approach.
Absolutely.
I think that's one of the most important factors, is it really is a team approach. And patients may say, I'm done, I don't want to do this anymore. And it might not be because of the physical pain, because we like to think that we do a really nice job in managing physical pain. But pain is not always about just physical pain. And so the social worker and the chaplain and the nurse practitioner and the physician and the nurse case manager all become involved in the management of that distress, so to speak.
Do you find that a number of people in supportive care are being treated for some form of depression or anxiety? I know, for example, my grandmother suffered from Alzheimer's and was on a SSRI at one point. I'm not sure if that had maybe something to do with the disease, a way to manage the disease, or if it was the depression that she was feeling. But is there a correlation between those two things that you find?
So what I often find is it's not the norm to be depressed. So if someone is presenting with signs of major depression, it's not normal. So it's not something that we say, well, you have an advanced cancer, so we expect you to have major depression. We expect that you have no joy in life and that you're sad and crying much of the time. We wouldn't find it normal, and we would absolutely treat it like we would treat any other patient who presented with depression. So we wouldn't expect that.
Very often, patients come to us, whether they have heart disease, lung disease, Alzheimer's disease, Parkinson's, it really doesn't matter. They often come to us on antidepressants. And quite honestly, when you can begin to have these conversations with the patient, when they can relate to speaking with someone about what matters most to them and what are their goals of care, and that's a very natural conversation, very often it really is the family who is struggling more than the patient surrounding that. So as Lorie said, we don't see major depression a lot at end-of-life care, and I think it's because of all of the support that we're able to provide.
And we have grief specialists, or at least a grief counselor, with Southcoast VNA who deals specifically with. I know in a few years back we were very fortunate to have a patient and her family who was willing to allow the Standard Times to kind of follow them through the last stages of their lives. And I know one of the services that we were providing was to her granddaughter who was a teenager, and our grief counselor at the time was almost preparing the granddaughter for what had been at that point decided was the inevitable with the grandmother. So, I mean, there are facets to this program, and there are specialists. There are people who have specialties that can deal with a ton of different issues. And I know you've talked about a few, but and it's not necessarily your expertise. But can you just talk a little bit about this Camp Angel Wings that we offer for the children of who are grieving the loss of a loved one. We do the Hope Takes Flight, excuse me. Each year we release butterflies in memory of people who have been lost. Can you just talk a little bit more about just generally what other services?
Sure. I think it's important to realize that supportive care services are provided by a team. And the team of social workers in particular, and the team of chaplains secondarily, not really, and then the bereavement counselors are all part of that preparation. Not only preparation of the patient, but preparation of the family. Once the patient has died, we actually, our bereavement program, follow families for 13 months during that period of grief, offering reading materials, support groups. We are just completing actually grieving surrounding the holidays. I believe next week might be the last group for that. So there is a lot that can be provided, and it's provided during and after a patient dies on the hospice program.
Yeah, and you bring up the support groups. There are a number. I know that we add them when needed, and sometimes when the particular audience isn't there, we'll pull back on some support groups. But I know in the last 6 months at different times we've had widow and widower support groups. We've had just general bereavement groups. We had support groups for kids who have lost loved ones. We've had camps. We've had weekly meetings. So if you are in a situation where maybe you don't necessarily, maybe the time has passed for supportive care, maybe a loved one has passed and you need some additional help, it's not too late to come to Southcoast VNA and get support. It's not like you needed to be a patient,
absolutely
a family
not.
member of a patient
Absolutely
who
not.
we treated and we lost, and was lost. This can be your first introduction to Southcoast VNA as in our group. So those are those are posted on southcoast.org. We tried to get them out into community newspapers. But again, you can always come to southcoast.org or call Southcoast VNA to get the dates and exactly the descriptions of what those groups are and where they'll be meeting.
And Camp Angel Wings, Lorie and I both participated in
Yeah,
Camp
that's
Angel
very
Wings.
special.
That's an annual camp, and it's a weekend camp. We had probably 85 children and perhaps 100 volunteers at that camp. It's a 2-day camp, and there are activities that help children that are grieving, who might not know they're grieving or might be acting out in school, and the parents are just not sure what to do. And it's really, it's been so successful and beneficial. And many of the children that attend that camp are not children of Southcoast patients that have died.
And it's right here in Asonet,
It is.
and it's
Yeah.
free.
Yep.
We don't ask a lot of questions when you sign up level one. It's just we trust that it's your child is suffering from some form of loss and grieving, and it's a great program, and it's one that is in July generally.
It is.
July.
Mhm.
So we usually start to release information on that in April or so, and so if you have a child at home and you've recently lost a loved one, and this might be a service time, keep an eye open for the announcement for this year's Camp Angel Wings. It really is a phenomenal camp.
It really
Yeah,
is.
and you can also reach out to the bereavement director to get your name on the list to make sure if you're thinking about it now. We can take names now and then get the information when we actually have the dates at a later time.
The School Adjustment Council has also all received flyers in the geographies that we service, early on, April, May, so that if they have any children that they are particularly concerned about, they can have conversations with the parents. And that's often how we get a lot of our referrals for Camp Angel Wings.
Excellent. Let's take another break. We'll be back in 30 seconds.
Teamwork is indispensable. We don't have cardiology and cardiac surgery separated the traditional way.
All these people come together and treat the one patient. It takes that collaborative effort to provide the best care for patients.
That's what makes us different at Southcoast Health.
We're one of the best cardiothoracic surgery programs in all of New England.
That is more than medicine, I would say.
So welcome back. We are in our final segment here, so please send along your questions for Robin and Lorie. Again, anything about supportive care services. Supportive care services, again, are palliative hospice care. And just in case people are joining us or just recently joined us, if you don't mind, just once again kind of describing what palliative and hospice care is and the difference between the two, and just kind of walking us through that general conversation again.
Sure. So palliative care is a medical subspecialty, so it's care for patients who have any type of serious chronic or progressive illness. It could be serious heart problems, lung problems, cancer, dementia, whatever it might be. And our role is to help provide symptom management support. So symptoms could range anywhere from fatigue, pain, nausea, whatever it might be that you're dealing with related to the treatment or the disease itself. Our job is to make sure your quality of life is as good as possible and those symptoms are well managed. Our role is also to help with advanced care planning, ensuring that you've identified someone who would be your decision maker or healthcare proxy, and that you've had those conversations about what matters most to you and what your wishes would be.
And hospice is intended for patients that have a life expectancy for 6 to 12 months. I think that's important to point out, and I think that's important for people to hear. Very often we will get referrals in the last days of life, and it's really not enough time to establish those relationships and provide the amount of support that can be provided. Hospice is a benefit, and I think people need to remember that. It's a benefit that they have to allow them to keep themselves, their family member at home throughout the remainder of their illness. It is an entire team that manages the patient: nursing, health aides, social work, chaplain, volunteers, bereavement, nurse practitioners, really the whole gamut. And although we can't be in the home 24 hours a day, 7 days a week, we are available. We have an on-call service after hours, and we'll make visits whenever needed.
Yeah, so that's a really good point that you bring up. Can you talk generally about the routine for a nurse who would be assigned to a patient? What is kind of the routine that you see as far as when do they come, when do they go? Does it vary depending on the patient?
Well, every nurse manages their own caseload, and they develop a plan of care in conjunction with the patient and family. And so if we have a patient that is experiencing increased symptoms, that patient might be seen every day until those symptoms are managed. We might have another patient who is actually quite well managed at some point during the process, and that patient might be seen once a week. So it really is very patient specific. That nurse is responsible for working with the family to determine, do they need a health aide? How many days a week do they need a health aide? Do they need a health aide 7 days a week to help with personal care? How about volunteers? We always have the volunteer coordinator call the patient and family and offer their services. We always have the social worker and the chaplain call and offer their services. So it really is a team approach, and depending on the patient's illness, depending on where they're at in their disease process, will depend on the amount of service that's provided.
So a couple of the hidden benefits. You mentioned that insurance will cover some of the equipment that is necessary.
It covers all of the equipment, actually, that the patient is going to need, like a hospital bed or a commode or an air mattress or a Hoyer lift or a wheelchair, a walker, a cane. All of those things are part of the hospice benefit.
So that alone, for someone who's trying to care for a loved one on their own right now, that alone is a reason to look into this, because that can give you access to a ton of equipment that would just, will make everyone's lives so much easier.
Right.
And along with hidden benefits, one of the, again, going back to the patient that we were fortunate enough to follow her journey, one of the things that I saw when I was there was the volunteers who come to spend some time with the patient, and how much of a benefit that is for the loved one who is
It's
caring,
huge.
just to get away, just to
It's
get
huge.
be able to just
Take
go
some
shopping
time, yeah.
for
Or go to
hours,
church
do
on
something.
Sundays,
Yeah.
The volunteers, we have some incredible volunteers. We have anywhere from 80 to 100 volunteers right now. We have volunteers that do Reiki, that do massage. We have a volunteer choir, which is quite unique with our hospice, and the choir will go to the hospitals, the nursing homes, patient homes, if that's important to patients and families. And you're right, volunteers provide that bit of respite that families and caregivers need, because it is a stressful time during everyone's life, and the volunteers can really provide some additional support.
We have a question here from Andrea, 2 questions actually. What is the biggest obstacle in providing the highest care for patients, and are family misconceptions about hospice a problem?
I definitely think family misperceptions are a huge problem. Thank you for your question. I think the myth that hospice is for patients who are right at the end of life, that you can't be walking around and be on hospice, and you really have to wait till you're on your deathbed. And we do a lot of education around that to provide that it doesn't have to be that way. If you qualify, if you don't have any further treatment options for your illness and you qualify for hospice, and you're appropriate, you could still be pretty active. So I think the misperceptions around that, and also the misperception of hospice is giving up. We try to provide education around that, because it's absolutely not giving up. It's really signing up for the best quality of life you can for the time that you have left. And I think once patients are on hospice, a lot of times families will realize, okay, now I know what this is about, and this is just extra support, and it's not, just medicating my loved one and leaving them in bed.
I think that's so important, when People think about hospice, they often say, well, it's giving up hope, and it really isn't. It's about a different kind of hope, and the hope is for a different quality of life, and maximizing that quality of life. As a hospice director, there have been many times where we have gotten a patient to their last Red Sox game, or we've gotten a patient to La Salette for the last time, or we've taken them to the beach. Again, it's really all about what is important to that patient, and how can we meet that need.
So question here from Tricia, circling back, we talked about morphine, we talked about how there's a perception that we give morphine to end a life. So the question here is why does that, I guess the question is, why does that perception exist? Why do people feel like people die soon after getting on medication? What's kind of the real explanation behind why that ends up happening? Is there an explanation?
It's hard to know why that misperception exists. I think perhaps we can try to provide more education about the disease process and what the morphine is specifically being used for. People hear the word morphine and they immediately think, well, that's an illicit drug. And it's one of the staples in hospice, quite honestly. We can have patients that are receiving IV morphine and be walking in the grocery store or the mall, or they're using that morphine to control their symptoms. A cardiac patient, I think, is another good example. Cardiac patients often require the use of morphine to decrease the effort with which it takes them to breathe. It's very effective. Excuse me. Their comfort level is greatly increased, and therefore the quality of their life is improved. So I think we need to do perhaps a better job as clinicians educating patients and families about the use of morphine.
And I think part of it also comes from in the past where people would come on hospice within their last days of life, and it just coincided with, well, they got morphine, they died, but they had caught on service so much later, really in the last few days, and they were having escalating symptoms and they needed the morphine. So then the family correlates that with, well, mom got morphine 20 years ago and she died the next day. I'll never have morphine, or I'll never give my loved one morphine. So it's providing the education, like Robin said, around the disease process and why it's used.
And really bringing patients on earlier to hospice. So we like to talk about, again, the benefit of hospice. We want to have patients on for 6 months. We want to have patients on for a year. If we can bring patients on sooner in their disease process, then much more education can happen. The relationships develop. The trust is there. Those are all very important things as a patient is in their final stages of life.
And Andrea asked another question here. She says that her father died recently, didn't have a will, caused a lot of confusion. Is there anything that she should do now, even though she's healthy and in her 40s? And I think that goes back to what we were talking about earlier.
Absolutely.
About health proxy, will, it's never too early to do it.
No.
Yeah,
Never too
our
early.
conversation nurse Sandy will often say, it's always too early until it's too late. So I'd say if you're thinking about it, the time to do it is now, because I can only imagine how it was with your father, that it was stressful and chaotic for everybody, and it caused a lot of additional stress during an already stressful time. So I would say if you can have the conversation with your family now, identify someone who would be your decision maker, do that now. Even just talking about, you don't have to talk about life support specifically, but even just saying, look, this really is what matters most to me. This is how I want to live my life. Start that conversation now.
And the will process is generally functionally it's an easy process. I think it's a difficult process to kind of sit down and really face your mortality and think about what's going to happen when you die.
Well, even for your healthcare proxy, it's a free form. You just need 2 witnesses. It doesn't even have to be notarized. So doing your healthcare proxy is very simple and straightforward, that you don't even have to go to a lawyer for that.
All right. I think we're gonna. There's a question here from Tricia. I'm sorry, Tricia. I don't fully understand the question. And actually our time is up, so I apologize. But we will be back next week with Dr. Podkow will be back. Thankful for everyone. You'll still have to see my face, but you won't hear my voice as much. and we hope to be joined by Dr. Holly Alexander, who is she's a primary care doctor, but she's also an addiction specialist. And in this time, and as we hit on, in this time when we have a lot of people who are addicted to opioids and other drugs, I think that what we will be able to hear from Dr. Alexander next week is going to really be important to a lot of people. So we hope that you tune in. Again, 7 o'clock Wednesday, Health Plus Weekly. Please join us here. Thank you to Robin and Lorie for taking the time to be here tonight.
Thank you for having us.
We hope that everyone that watched, took away something from this, and this will make whatever they're going through a little bit easier on them. So we'll see you back next week. Goodbye, everyone, and have a great night.
Thank you.
Thank you.